Good morning. I am going to talk for the beginners. I am going to talk for the persons, for the minds, for the brains which are struggling for the hysterectomy. I am going to talk for the persons who do the laparoscopy and they feel they are not able to do the TLH, and this today's lecture is for that. Okay. गुरुपौर्णिमा आहे, तर एक जस्ट एक माझ्या टॉपिकशी रिलेटेड गोष्ट आहे गुरूंची. आपल्याला माहिती आहे की एकदा आहे ना, द्रोणाचार्य, ही सगळ्यांना गोष्ट माहिती आहे की द्रोणाचार्य, अर्जुन आणि हे सगळे विद्यार्थी आहे ना, त्यांचं कॉम्पिटिशन घेत होते. आणि समोर असं एक माशाचा डोळा होता, मागं चित्र होतं, आणि ते बाण मारायला सांगत होते इकडून तिकडं, आणि प्रत्येकाला बोलवलं. मग पहिल्यांदा दुःशासनाला, तुला काय दिसतं? तर दुःशासन म्हणला, मला ते डोंगर दिसतात, मला ते झाड दिसतं, मला ते पक्षी दिसतो, मला ते वॉटेवर पक्षी दिसतं, आपण माशाचे पक्षी म्हणूया. ओके. नंतर मग कुणाला तरी बोलवतो, म्हणतो मला पक्षी दिसतो. आणि मग अर्जुनाला बोलवलं तर अर्जुन म्हणतो मला फक्त डोळा दिसतो. तर अर्जुन एकदम गुरु खुश होतात. पण आता त्याच्या पुढची स्टोरी आहे. मग आता तू बाण कसा मारशील ते दुःशासनाला विचारतं. दुःशासन म्हणतो मी असं धनुष्य घेईल, असं ओढेल आणि असा बाण मारेल. ओके. तर मग अर्जुनाला बोलवतात ते. मग अर्जुनाला विचारतात की तू बाण कसा मारशील? मग तो म्हणतो मी स्वतः तयार होईल, मी माझी मान अशी तिरपी वळवेल, 2 पायामध्ये 1 फुटाचं अंतर करेल, पुढचा पाय थोडा तिरपा करेन, मग माझं धनुष्य आणि ते दोरी एकदम एका रेषेत घेईल, माझं बाण, माझी दोरी आणि तो त्या पक्षाचा डोळा एका रेषेत आहे की नाही ते मी बघेन, आणि मग मी माझा बाण सोडेल. तर गुरु म्हणतात तरी 100 पैकी 90च मार्क. तर म्हणे का सर? तू तुझा तो पायाचा अंगठा आहे ना, त्याच्यावर तू बॅलन्स नाही केलं म्हणे तुझी पोझिशन, ते लक्ष प्राप्त करण्यासाठी. तर समहाऊ मला वाटतं आपण ह्या TLHकडं या पक्षाच्या डोळ्याप्रमाणे बघून जस्ट एक बाण मारल्यासारखं ॲक्शन जशी असते की फक्त बाण ओढला आणि बाण सोडला आणि लागला असं न करता, की प्रत्येक स्टेप जी आहे, just like we are going to divide that step, like there is a book, then there is a topic, and there is a, in topic there is a sections, and in section there are the paragraphs, and there in the paragraphs there are the so many lines, and every line has its own importance. Like the same, we are going to today discuss the TLH. I don't say I am going to teach you the TLH. So my first point is, how do you prepare yourself for the TLH? Yes, I said I am going to speak for the beginners. तुम्ही स्वतःला कसं प्रिपेअर करणार TLH? आता फर्स्ट थिंग, ॲटलिस्ट यू शुड परफॉर्म 30 cases before the TLH, the simple cases like the level 1 surgeries, like the diagnostic scopy, like the TL, like the cyst, like the ectopic. Don't start your laparoscopic career with the TLH. ओके. आपल्याला सगळ्यांना आतून एक ऑरा असतं TLH करायचा किंवा लोकांना दाखवायचं की मी TLH करतो. बट डोंट फर्स्ट डू द 30 cases. संयमाने 30 cases करायच्या, बिकॉज लॅप्रोस्कोपी हॅज इट्स ओन कॉम्प्लिकेशन्स अँड TLH हॅज इट्स ओन कॉम्प्लिकेशन. वी डोंट वॉन्ट टू कंबाईन बोथ द कॉम्प्लिकेशन्स प्रोसिडिंग विथ द स्टार्टिंग विथ अवर करियर विथ द TLH. सी, आय नो द एव्हरी गायनेकॉलॉजिस्ट इन द हॉल, इन द एरिया, इन द प्रत्येकाला ना TLH करायची असते. But we don't prepare ourselves for the TLH. Mind preparation नसतं आपलं, and we don't prepare our surroundings for the TLH. Then the second point, I said one point is you should at least do the 30 cases. Second point, how do you prepare yourself for the TLH? So if you are following one technique, just like I have one technique, just like the Borsesser have one technique, Mate has one technique, and there are 100 techniques available on the YouTube. So the best way to do TLH is like that: 2 points from the Vikram, 2 points from the Pankaj, 2 points from the YouTube, 2 points from the whatever, and you will combine all the points together and you will perform the best TLH. No, not like that. Whatever you are going to learn with your boss or with your mentor, whatever the steps 1 2 3 4 5 to 10 steps, that steps you have to repeat 100 times till one certain level of your I mean the duration. असं बिलकुल म्हणजे when you take 2 best step from the Vikram, 2 best step from the Dinesh sir, and will do the best TLH, असं नाही होत. बिकॉज I will always used to say ki just follow your boss for some particular period for the 3 to 5 years and do the same steps. तेच व्हिडिओ बघायचा, एकच TLH बघायची 100 वेळेस, उलटी येईपर्यंत तीच TLH बघायची. Then only you can understand the importance of that one steps, how many minute steps in that one step is available. So today our focus is just, I like the word the beginners. So I am going to talk for the beginners. I have only 3 slides. This is the prerequisites, second was the preparation, and the technique. So the prerequisite I already said, ki prepare yourself for the TLH when you are, one is that at least 30 cases, and what skills you should know before doing the TLH. What skill? काय आलं पाहिजे तुम्हाला? काय आलं पाहिजे TLH करण्याआधी? काय आलं पाहिजे? टोकर टाकता आलं पाहिजे, राईट? अजून 2 इन्स्ट्रुमेंट जे पोटात टाकतो, ज्याला हँड्स ऑन ट्रेनिंग म्हणतो आपण सगळे, त्यांचं एकमेकांसोबतचं कॉर्डिनेशन आलं पाहिजे, राईट? थर्ड तुम्हाला ट्रॉली अरेंजमेंट आली पाहिजे. फोर्थ तुम्हाला कार्ट अरेंजमेंट आली पाहिजे. फिफ्थ तुम्हाला अर्गोनॉमिक्स आलं पाहिजे. ओके, दिस आर द बेसिक रिक्वायरमेंट फॉर एनी सर्जन हू वॉन्ट्स टू डू द TLH. ओके, सो व्हॉट वी स्टार्ट, आपल्याला डायरेक्ट कॉर्नर पकडायचे असतात आणि डायरेक्ट त्याला कॉग्युलेट करून कट करताना शिकायचं असतं. पण ह्या सगळ्या गोष्टी आपण आल्याशिवाय आपण TLH करायला नाही पाहिजे. आय ऑलवेज यूज टू से की ट्रोकर एंट्री इज द इंटरवल ऑफ द मूवी. अर्धा पिक्चर तर त्याच्या आधी असतो. ओके, सो बेसिकली फॉर द TLH, सो तुम्हाला ह्या सगळ्या गोष्टी आलं पाहिजे. म्हणजे आपण एक सिझेरियन सेक्शन ऑपरेशन शिकण्यासाठी 3 वर्षाची रेसिडेन्सी करतोय असं म्हणूया ना, बरोबर आहे? एक सिझेरियन सेक्शन ऑपरेशन शिकण्यासाठी आपण 3 वर्षाची रेसिडेन्सी करतो. आपल्याला आपला CR आधी इपिसोडोमी द्यायला लावतो, बेबी डिलिव्हर करायला लावतो, नंतर मग तो ॲबडोमिन स्किन सुचर करायला लावतो, नंतर युटस सुचर करायला लावतो, नंतर बेबी डिलिव्हर करायला लावतो, आणि नंतर आपण एक कंप्लीट सिझर करत असतो. आणि फॉर TLH, फॉर द लर्निंग ऑफ द लॅप्रोस्कोपी, तुम्हाला फक्त ते 15 दिवसातच पाहिजे असतं. ओके, सो द लॅप्रोस्कोपी इज आय से इट इज अ ड्युरेशनल लर्निंग. ओके, इट इज अ न्यूरोमस्क्युलर डेव्हलपमेंट ऑफ युअर बॉडी. यू सॉ द कराटे किड मूवी, त्यामध्ये ते एक नुसतं हात असं ते साफ करायला लावत असतो. त्याचा आणि ते फाईटचा उद्देश, म्हणजे त्याला वाटतं मी एवढं अमेरिकेतून या चायनामध्ये कराटे शिकायला ना, मला काय असं आहे कराटे साफ करायला लावतो. तो सो व्हॉट स्टेप्स we are going to develop, just like the compile when we are going to learn laparoscopy, it is a composite learning of the observation, assistant, vaginal assistant, and the hands on, not only just the hands on. So these are the important preparation. So then when we say it is a easy hysterectomy, now you are now prepared, you have done the 30 cases, you know the trocar entry, now you are planning for the TLH, you are the beginners. Okay, when you say, what do you select? I know one my junior who selected the case for the TLH is the 18-week size uterus and HIV positive patient, and that TLH will be going with his first म्हणजे त्याचे फर्स्ट TLH राहिली असते ते. सो द प्रॉपर सिलेक्शन ऑफ द पेशंट्स फॉर द बिगिनर्स इज व्हेरी इम्पॉर्टंट. वेन वी से इट इज अ इझी हिस्टेक्टॉमी, वेन वी से इट इज इझी हिस्टेक्टॉमी, ओके, फर्स्ट आय से की वेन patient should not be obese. Second, mobility should be good. Fourth, always look for the sonography dimensions of the uterus. Okay, I removed the 20-week size uterus. सोपी असते हिस्टेक्टॉमी कधी कधी 26 वाईज युटरसची. बट व्हॉट इज इम्पॉर्टंट, द ट्रान्सवर्स डायमीटर, पेल्विक डायमीटर, मोबिलिटी ऑफ द युटरस, दॅट इज व्हेरी इम्पॉर्टंट. देन स्कार युटरस. आपल्याला ॲज अ बिगिनर वी डोंट वॉन्ट टू डू द TLH फॉर दिस पेशंट, ओबेस पेशंट, स्कार युटरस पेशंट्स, ज्यांची पेल्विक डायमीटर, द ट्रान्सवर्स डायमीटर ऑफ द युटरस जास्त आहे ते, अँड when there is a compromised cardiovascular status. Okay, so the patient is already medically risk, don't try to do the TLH in that patient. Okay, then you have confidence to finish that TLH within 120 minutes at least, then only go for the TLH. Okay, otherwise you are performing TLH for the 5 years, there is काही व्हॅल्यू नाही त्या गोष्टीला, राईट? सो always select the simple patient. Okay, then it will be always have your proper team. Proper team means your assistant. Okay, always if you have colleague laparoscopic, that is always better for your first case. Go with plan. What is plan? आदल्या दिवशी 3 दिवस आधी पेपरवरती सगळ्या स्टेप्स लिहून काढायच्या. ट्रोकार कसा टाकायचा, ॲबडोमेन कसं पकडायचं, हा ट्रोकार कसा टाकायचा. जस्ट गो फॉर द शॅडो ट्रेनिंग. व्हॉट डू मीन बाय द शॅडो ट्रेनिंग? की स्वतःला तुम्ही केस करता असं इमॅजिन करा. जस्ट लाईक दिस आय ऑलवेज यूज टू से की तुम्ही इमॅजिन करा केस करताना, प्रिपेअर करा. ऑब्वियसली just prepare, do the trolley arrangement, remember the every steps. Definitely you will be better prepared for that TLH at the time of the performing. नसतं आपण जातो TLH ला आणि आपल्याकडे एक इन्स्ट्रुमेंटच नसतं, हेच नसतं, तिथून सुरुवात होते, अनसाठी चिडचिड करत असतात. then definitely your confidence will be low at that time. So we have to go for that TLH with better confidence, better preparation, better team and better environment. Okay, one important point, the table selection. ऑलवेज ज्यांचे नवरे ऑर्थोपेडिशियन आहे ना, ज्या गायनेकॉलॉजिस्ट बायकांनी तर भांडून गायनेकचा टेबल घ्यायचा, कारण की त्या फलक्रम जे असतं ऑर्थोपेडिक टेबलचं, युरो टेबलचं वरती असतं आणि ते पेशंटचे पाय जातात डोक्यापर्यंत आणि इट बिकम्स अ डिफिकल्ट TLH. सो इट शुड बी ऑलवेज अ गायनेक टेबल, इट शुड बी ऑलवेज अ गायनेक टेबल फॉर द पेल्विक लॅप्रोस्कोपिक सर्जरी. आपण हे बघतच नाही. अदरवाईज हॅव अ बेटर स्टँड टू स्टँड ऑन दॅट प्लॅटफॉर्म. अरेंज करा ते 2 दिवस आधी. आप तुम्हाला TLH करायचे. आय एम टॉकिंग फॉर द बिगनर्स. जे आता उद्या TLH करणार. ओके, प्लॅटफॉर्म बघा. प्लॅटफॉर्म नसेल तर 2 पार्ट आणा घरातले, त्यांना जोडायचं आणि त्याच्यावरती उभं राहायचं. डेफिनेटली द TLH बिकम व्हेरी इझी. ओके, सो नाव आता सगळं यू आर रेडी, एव्हरीथिंग इज देअर. नाव विल गो फॉर द टेक्निक्स. ओके, आय कन्सिडर्ड की यू नो द ट्रोकार एंट्री, यू नो द एव्हरीथिंग, अँड नाव विल गो फॉर द TLH. I have made my some points. I say कि this is a easy hysterectomy, difficult hysterectomy when. So this is a simple TLH for the. So when the uterus move like this, I say this is a simple hysterectomy. Okay, right. Okay, some I am a surgeon who stands on the left side. I always use the uterine manipulator. Someone use the Myma screw. Apla technique है. No one technique is better than other technique. Okay, which technique is better? The technique which helps us to do the TLH, for example, one point. Second point, we can complete the TLH without a complications. ज्या प्रोसिजरमध्ये कॉम्प्लिकेशन होण्याची शक्यता कमी, दॅट इज अ बेटर टेक्निक फॉर द बिगिनर्स. ओके, नाव सो हिअर आता नाव I say when there are the 6 point is visible, 2 cornu, 2 uterosacral ligaments and 2 the guards of the prawns, the manipulator. When I say it is a easy hysterectomy. So now beginners आता सगळ्यात जास्त डिफिकल्ट असते बिगिनर्सला कॉर्नो. ओके, व्हेन यू डू द कॉर्नो बोथ साइड्स you will get the 50% confidence. Now I am coagulating. When I am coagulating this cornu, that there are the 4 structures: ovarian ligament, tubes, round ligament and the mesosalpinx. So here for beginners you can hold all 4 structures together and coagulate, but beginners you should hold all these structures separately and coagulate it. Don't cut first, coagulate everything and then cut. Okay, definitely you can cut immediately, but initially what happen, if you coagulate and cut and it starts bleeding, तुमचा confidence कमी होऊन जाईल. Okay, so what I just how I am coagulating, I am holding, that is 1, that is 3 and in between that is 2. This is coagulate till just bubble stops. Okay, the same other, this is your scissor which is going to help you for the cut. Okay, when you cut you make a U, right? This is a U. There is a U-shaped or V-shaped opening is there. Now again always coagulate. What we say always, coagulate more, cut less. Remember, coagulate more, cut less. So when you try to coagulate all together, sometimes the inner part we cannot able to coagulate. Okay, so when again here is a V is created from the ovarian ligament and the tube and the round ligament V, and they try to join all these structures. So what is important here, just stretch and the important, and see what is my other instrument is doing, just I am just pulling the ovary. Okay, so try to help the strain. इथं गडबड नाही करायची. If you do the both side काढून आपल्याला वाटतं अर्धी हिस्टेक्टॉमी झाली. Okay, so and always going to cut between the 1 and 2. Okay, means 2 and 3 goes to the lateral part, 1 goes to the your specimen parts, which helps to prevent the spill from the specimen. If there is a bleeding where you are going to coagulate, there is a crust formation, the transfer of the energy will be the difficult. So when there is a vascular structure coagulate into 1 2 3 pattern, now this is a peritoneum, so there is no need for the 1 2 3. Okay, so just 1 and 2, always both instrument take together. Some people use the sharer, that is okay. I always use for this structure bipolar and coagulate. There the instruments are perpendicular to the specimen. Here on the opposite side, when I am performing, my instruments are the parallel to the uterine wall. Okay, so from I say upper port is for the bipolar, lower port is for the scissor. Okay, this is a 2, this is 3, always count in mind, and this is 1. Okay, so how we are going to coagulate? Just till the bubble stops. If it is you find difficult to then just count 1 2 3 4 5 till 6, coagulate. Okay, the ask your vaginal assistant to give proper direction and the pressure. Okay, so if your assistant is good, ask your assistant to just give the proper traction or use that instrument as a guard. तुम्ही मला प्रश्न विचारू शकता. वी जस्ट थिंकिंग आय एम परफॉर्मिंग दिस केस. ओके, so now what is important here is the just I am coagulating clotting, but when I am pressing on the uterus, that is also important point to just give the tractions by the scissor. Okay, so when we go for the corno, always don't do it with patience, slowly. I always prefer go simultaneously. Borsesar always say ki go simultaneous. Some people used to go from one side to till the opening, but go simultaneous attachments. Okay, what is dictum? There are some principles. Right, work always for the difficult case. Go the simple step first. When we do the simple step, we can found the answer for the difficult steps also. So both corno we seems it is a simple step for the beginner. तो दोन्ही साइडचे corno आधी करून घ्यायचे. Okay, because sometimes bladder dissection become difficult. One side corno is attached there. So your instrument should be parallel to the lateral wall of the uterus. Now, so this is the two steps. The corno. The next step will be the bladder dissections. I have uterine manipulator. Okay, so during this time I retroate the uterus. Before that the uterus is anteverted. Okay, so uterine, this is anteverted uterus. Just for the showing I am doing this, and this is now retroverted uterus. Okay, I am pushing the uterus away from the attachments. Now I do the bladder dissection into the 3 steps. So you saw the on right side there is a V created at the round ligament. I the catch that I am going to connect this V to the opposite side. I am always do with the bipolar and scissor. Simple. This is there is some white line at the junction of this free fold of the peritoneum attached to the uterus. That point, with the guidance of that point, I am going to cut the upper layer of the peritoneum only. So this is the first step. I say this is a for the bladder dissection. Definitely for the previous cesarean section, difficult hysterectomy, this is a difficult. So just see, just by cutting this attachment, bladder goes away. Just a single cut and at least 1 centimeter this peritoneum goes away. Now the second step will be the actually the part of the bladder dissection we are going to do. It is said that if you do the bladder dissection, you can do the hysterectomy. So I am holding the and cutting just above the uterus attachment. There is a one layer, not completely एकदम खरडून नाही काढायचं. There is a one layer belongs to the uterus. Okay, so see the vascularity is there, and some the vessels are into the upper part of the and the cervix. Okay, so pushing, and this is a right pubovasico and the uterine the ligament, we say the uterine bladder pillar. Okay, so with these 2 steps we completed the 80% dissection of the bladder. Just okay, don't try to do the 100% complete dissection, because when there are some part of the attached to the uterus, like the bilateral uterine arteries, when it goes away, definitely the remaining part of the bladder dissection becomes easy. Like so, these are the prawns, the vaginal manipulator. with the help of I am doing this. Now the uterine artery. So like the open, I first will do the posterior peritoneum. Again there will be no need for the 1 2 3 place, just a single coagulation and cut. So definitely you will find the path. Just follow that path and cut in between the, see the coordination of both instruments, both are together. There is a minimum distance between the two instruments, right? So just before doing the uterine, your bladder dissection should be completed, posterior peritoneum dissection should be completed. Okay, so again this is a vascular structure. What I said, there is a 3 points where I am going to coagulate. So 2 points goes to the lateral, 1 is goes to the with specimen. I am going to, and when you hold this uterine, okay, so just give the pressure to the uterus, push it away, and now this is 1, this is 3. Okay, so make it simple, try to just push the surrounding structures down. Okay, see when uterine we are going to coagulate and cut the uterine, and uterine retract goes down, definitely the next remaining bladder which help us to for the dissections. So always make it objective. So okay, so the constant pressure and direction is required by the vaginal assistance. Okay, so this is some part of the Macton rods and uterocycles. Okay, if there is a bleeding from the specimen side, definitely we found it is difficult to coagulate. Okay, now there is a upper, there is a crust formation here is little bit. Okay, so which is a bad conductor of the cautery. Okay, again which becomes the difficult. Okay, so now this uterine we are going to do the inverted V for the dissections. The invert, just see that at the tip of the attachment of the uterine is the tip of the U or V, and this is a one leg of the V or U. So you take a inverted U or V dissection for this uterine artery dissections. Definitely see the, when uterine falls, definitely the remaining bladder dissection becomes easy, right? See now there is a one imaginary line and there is a one path, just follow that path. One leg in the path, one leg is outside the path. Do the coagulation and the cutting, right? This is the outer border of our path. See, I am showing this. When you are going to coagulate, always pull up. Okay, just pull and then coagulate at the same place, because uterine artery has a tendency to get retracted after the cutting. Okay, so see my bladder dissection, it happens automatically, so don't try to do 100% bladder dissection initially. Okay, when the attachment goes away from the uterus, the like the bladder also goes from the that when we go to the dissection for that point. Okay, so this hard part is the guard of the manipulator. I am the surgeon who is using the vaginal manipulator. Some people use this. Okay, so this is a guard of the manipulator. With that I am trying to push the uterus away from the ureteric system. Okay, at this point after the dissection of the right uterine artery, again I will retrovert the uterus. Okay, and again I will bring back the lower your cervical part away. So here I take a initial cut into the cervix, just a very simple initial cut which help me to push away the ureteric system again, and again it is said that the neurovascular the of the bladder is well preserved in this technique. Okay, so and we are more safe. Okay, if at the time of suturing again we know the from where you need to catch that point of the vagina for the suturing. This is a opposite guard of the manipulator. See the direction of is like ask your vaginal assistant to, so that you can easily dissect that part. If it is in opposite direction, that means it is a downward side, it is definitely difficult dissection. So again for the second uterine I will do the antiversion. Same again here my principle is just pushing and pushing the uterus away, and my instrument should be parallel to the uterus. The maximum times the ureteric injury for the beginners happens for the opposite side of the uterine artery, because we don't work on the direction. What is our direction? The instrument's direction should be parallel and close to the uterus. If it goes toward that point away, so the chances of ureteric injury is there. If you are not pushing the uterus properly, and if you are not having the control over the direction of your instrument, this can happen. So again, the posterior dissection I am going to do. So this is a, just I forward it. So the same up to the uterus axis I will dissect. See, this is the upper part of the attachment of the cornu is there. So this is not a uterine artery where it, so I am skeletalizing here uterine artery. Go layer by layer, go millimeter by millimeter. We don't have any always. Now this, just don't watch the bipolar, watch my scissor also. I am pushing that uterus back, I am making it is in my angle. Okay, so what is the, it is coagulation cutting is a one part of surgery. What is important? Bringing the specimen into the position, that is more important. That's why we say when is a bigger size uterus, why it is a difficult? Is it difficult because we are not able to coagulate or cut? We can coagulate and cut, but it is difficult for us to bring it in position. So how to bring in position, how to keep in position, that is also important skill to do the laparoscopic hysterectomy. Just coagulation cut तर येणारच आहे ना, येतच आहे ना ते आपल्याला, पण bringing and keeping it in the position, that is very important. Okay, so in my case up to this I will do with the bipolar, and from this I use the bipolar cutter. Again for that, for the beginners, how to use, for 1 2 3 3 times coagulate, and when you are going to cut, just hold it half of that initial part. So for the coagulation, hold full, coagulate for 1 2 3 times, and for cutting you just hold it half, it will cut easily. Right, this just for the showing I am doing this, right? So after this I will take a simple cut, or and the making and thinning the Meckenrod's ligament. Okay, so now my target is to open the vault, open the vagina, right? So this is a one outer border and voltage border, and in that border only I am going to cut it. See, just don't try to poke at one point and try to open, make it thin. Just like the saloon मध्ये cutting कशी करतात ना, छोटे छोटे केस कापतात, पुन्हा छोटे छोटे केस कापतात, like that goes for this cutting. Okay, don't and the other just see, that is a skill, because we have a judgment to how much deep we need to go. Okay, so again the constant traction and the stress is maintained by the vaginal assistant. So this is the opening of the vault. Here this is a vaginal delineator tube. Okay, I am inserting, and at this time I am inserting the myoma screw, and I am applying this myoma screw at the level of the isthmus. My aim is to give the traction. The counter traction is helped by the vaginal assistants. Okay, so which help me to have a proper cutting at the level of the cervico-vaginal junction. Every time what we say, coagulate more, cut less, but at this point I will say coagulate less, cut more, because I want less slough formation. Okay, so this is the you can go anteriorly and you can go posteriorly for the cutting of the vault. Okay, some people do with the harmonic, that is okay. So this, because of this traction, you can easily identify the junction, and you can have a complete removal of the cervix, and again the removal of the retrieval of the specimen is by vaginally. So actually say this is a TLH is completed. Okay, if you don't know how to suture, it is okay, you can suture vaginally. Okay, so for the suturing, just for the beginners, now this is just I want to discuss this point. Now when you are performing removal of the ovary, removal of the tube, what is important? Okay, when what is important for this? Okay, how to, when you are performing this, what is important? Grip is important. Coagulation cutting is not important. Grip, this is not good grip. So what is my aim is to have a good grip. Okay, this is, now I have a good grip, right? So keep this structure away from the bladder, away from the anterior wall, away from the bowel. Okay, this picture should be always into the center. Okay, so again 1 2 3 I am coagulating. Okay, now this is just have a coagulation. If I am going to cut here, now here coagulating towards the specimen, and you are going to cut laterally, that is called as shake chilli cut. Okay, so your coagulated part should be lateral because that is hemostatic. Okay, so when you are going to cut, have a hold the small tissue. Okay, don't try to hold the complete tissue. So what is important here is the traction. Like this you can, so always have a look on the ureter when you are performing the these adnexal structures. If you have good tractions, the chances of injuries definitely will be less. Okay, so suturing, I think suturing not needed to discuss, as it is not part of the TLH. Okay, okay. Okay, so suturing. Okay, this is now suturing. I am going to use the needle holder, and other than is the Ellis in one hand. The needle, I am the right-handed surgeon, left-handed surgeon. Still, I am using the needle holder in the right hand. Okay, with practice you can do it. Okay, I start from the opposite angle. Okay, for the suturing, so I feel when the you have needle holder in the lower hand, so the for the bladder separation it is easy. Okay, make a loop, the 90-degree angle. Okay, so this is a 90-degree angle. Go into the pelvis for the suturing and have a loop. Okay, 3 loops is okay, and when pulling, give the little bit traction. Okay, again place the knot back. When you hold the near to the always try to hold near to the stitch, so which has a better traction. Okay, so I always will take the uterus cycle into the next stitch. Okay, so for the beginners, first is a 3, second is a 1, and third one is a 1. Okay, so don't try to do the more knotting at that place. Now uterosacral. I always take a continuous suturing, not a interlocking. Okay, this is in short steps for the simple TLH for me. It can be different steps for you. Just follow that steps. Follow your one guide and follow that steps for 3 to 5 years. Then you can modify. Then you can add the other steps in your technique. But initial phase, just follow one technique only. Don't try to mix the number of techniques together. Okay. So I feel, and you should also feel, the my technique is the best technique for the beginners, because the chances of completing the procedure is good and chances of having the complication is less. बरोबर है? So you also have a faith in your technique. Okay, so thank you. Questions? Okay, I always go for the supraumbilical port. Okay, so it is a 2 centimeter above the umbilicus. Second, I am the left-handed surgeon. The for the routine uterine size I am talking. The lower port will be in the superior anterior superior leg line to the umbilicus, 2 centimeter above, not exactly 2 centimeter. That is one area. Okay, you have a look on the uterus. And me always say there is a one area like like वाळवंटा सारखा area दिसतो आपल्याला. One there is a the inferior epigastric, there is a, and there is a some shallowing area is there. In that area you should insert the trocar. Second is at the level of the second upper port is at the level of the umbilicus in mid clavicular line. Not exactly 2 centimeter margin in that area I insert the operating side, and opposite side again 2 centimeter above the anterior superior iliac sign. Again important part for the insertion of trocar, always when you are performing, 170 सेंटीमीटर हाईटवाल्या पेशंटचं ॲबडोमेन वेगळं आहे आणि 135 सेंटीमीटरवाल्या पेशंटचं ॲबडोमेन वेगळं आहे. ऑलवेज लुक फॉर द डिस्टन्स फ्रॉम अम्ब्लायकस टू द pubic symphysis and upper abdomen distance. If the distance is good, lower below umbilical distance is good, then you can have a similar size insertion the port for the upper trocar entry. If the distance from the umbilicus to the pubic symphysis is less, you can go above. So this is important point, the distance of the where is the umbilicus is located, and definitely if the size is bigger and the is bigger, then go little bit upwards. Okay, when you insert the first trocar and you saw the uterus, if you have a space into the pelvis, म्हणजे कसं की 28 सेंटीमीटरचा फायब्रॉइड आहे आणि वरती आहे पण खाली एकदम रिकाम आहे समजा, ते काय 20 मिनिटाची सिस्टेक्टॉमी असते, म्हणजे 30 मिनिटाची समजा असं म्हणूया. जर तुम्हाला कॉर्नर दिसत असेल, युट्राइन दिसत असेल, फक्त आपल्याला युट्रस मोठं दिसतं वरनं ॲबडोमेनल, बट यू हॅव गुड स्पेस, यू कॅन गो विथ द युअर रुटीन पोर्ट एंट्री ऑल्सो इफ यू हॅव गुड स्पेस इन टू द पेल्विस.
Sir, which vaginal manipulator you are using? And
This
second,
is
and second thing,
what you दाखवलं होतं.
and what you do if the fibroid is of very big size, like about 20 weeks?
Okay,
Can you repeat the same? Can you use the same vaginal
yes,
manipulator?
see what is important, I said ki to bringing the specimen into the position, it is important. Okay, this vaginal manipulator is not only for the manipulation, it is for the bladder dissection also, because this vaginal manipulator helps me retrovert and so that I bring the lower part of the uterus upward, so that bladder dissection become easy for me. So if it is a very big size uterus, still I insert the manipulator and I will use assistance port to, if it is I am not possible to manipulate the upper part or the corneal structures because of the bigger size of the uterus, in that case I will ask assistant to stretch and help me for the corneal structures. Very rarely I will use the myoma screw, because I feel with one myoma screw I will obliterate my one port, but some people are comfortable with myoma, that is okay. Sometimes of the insertion of the myoma for the beginners, म्हणजे ते हिस्टेक्टॉमीच्या ब्लिडिंगपेक्षा त्या मायमा स्क्रूचे ब्लिडिंग जिथं टाकतात ती ब्लिडिंग जास्त होती. ते टाकता नेमकं ते कॉर्नूमध्ये, राईट, वेन देर इज अ युट्राइन आर्टरी अँड द अम्ब्लायकर आर्टरी कम्स टुगेदर, तिथं मायमा स्क्रू टाकतो आपण. हां, तिथं म्हणजे ती ब्लिडिंग स्टॉप करण्यात आपले 30 मिनटं एक्स्ट्रा जातात पुन्हा, है की नाही. राईट.
Vikram, congratulations for the very demonstration of the best method of the laparoscopic hysterectomy. We have also learned so many things.
Okay, thank you sir. Best म्हणजे बेस्ट फॉर मी. ओके, बेस्ट फॉर तुमची बेस्ट वेगळी असेल, त्याला बेस्ट मानायचं आपण. ओके, त्याच्यात आपण क्वेरी ठेवली ना, मग तुम्ही कधी सेटल नाही होणार लॅप्रोस्कोपिक सर्जन म्हणून. ओके, तुम्हाला आज माझी चांगली वाटते, उद्या सरांची चांगली वाटते, तिकडं चांगली वाटते, परवा ती चांगली वाटते. लग्नासारखं आहे. राईट. पण मी एक वाक्य वापरलं होतं की 3-4-5 वर्षानंतर तुम्ही एक्स्ट्रा काही ऍड करू शकता, तिकडे नाही. राईट, राईट. सो जस्ट हॅव mastery one technique and follow that technique. It is nothing but the repetition of the same step. ओके, आपण गायनेकॉलॉजिस्ट आहोत, हे आपलं प्रिव्हिलेज आहे. आपण ह्या स्टेप करायला आपण गायनेकॉलॉजिस्ट असावं लागतं असं बिलकुल काही नाही आहे. प्रत्येक गावामध्ये 5-6 लोक असे असतात जे गायनेकॉलॉजिस्ट नसतात, 10वी-12वी पास असतात आणि ते कुठल्या तरी गायनेकॉलॉजिस्टला जाऊन शिकवत किंवा असिस्ट करत असतात. तुम्ही बघा ना, त्यांच्याकडून पण आपण शिकू शकतो की ते त्यांनी काय केलं, फक्त ते टेक्निक कसं करायचं ते फॉलो केलं. इट इज अ टेक्निकल लर्निंग. मला काय शिकवायची गरज नाही ना. फंडामेंटली युट्रस हॅज 3 लेयर्स आणि ट्यूब्स हॅज 5 सेंटीमीटर लेंथ आणि दिस पार्ट, ते येतं तुम्हाला. ते कुठं पकडायचं, कसं पकडून कॉग्युलेट करायचं आणि कसं कट करायचं, कट करताना कुठं आपण ट्रॅक्शन द्यायचं, दिस इज अवर लर्निंग. आणि दिस इज डिफरन्शिएट अस फ्रॉम द डिफरंट सर्जन. आपण म्हणतो दिस इज अ बेटर सर्जन अँड दिस इज नॉट बेटर सर्जन. आपण असं का म्हणतो, दोज सर्जन हू डज लेस अननेसेसरी स्टेप्स, दॅट इज अ बेटर सर्जन. कारण की लागणाऱ्या स्टेप तर सेमच आहे 17 फॉर एक्झाम्पल. जो एक्स्ट्रा अननेसेसरी करतो ना, तिचं थोडंसं मेसी होतं. जो लवकर शिकतो की अननेसेसरी स्टेप्स कमी कशा करायच्या, दॅट इज अ बेटर सर्जन. आय लाईक टू से. थँक्यू.